Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome back to The Deep Dive. Today we're tackling something absolutely foundational for anyone in acute care surgery or emergency medicine, acute cholecystitis.
A classic.
It is. And for decades, managing it was, well, all over the map. It often came down to just institutional habit or even a single surgeon's preference.
The Wild West, really.
Exactly. But that all changed. It changed with one single international gold standard. So today we're diving deep into the Tokyo Guidelines 2018, or TG18.
And, before we go an inch further, we have to put up the mandatory and really crucial reminder.
Please.
For all of you listening who are clinicians, the information we're talking about here, it's for review, for understanding. It's drawn right from the published literature on TG18.
Right.
But you must always follow your local institutional guidelines and protocols in your actual clinical practice. This is a reference, not a replacement for local standards.
That context is always key. Okay, so let's unpack this. Think back, before 2007, the mortality rates for acute cholecystitis were, well, they were kind of shocking.
They were all over the place. Sometimes 3%, sometimes up to 10%.
And that huge variability was basically because we didn't have a shared language. There was no unified way to diagnose it or to say how sick a patient actually was.
Which makes comparing outcomes impossible.
Totally. So our mission today is to give you a clinical shortcut right to the core of TG18. We're going to break down what it demands for a diagnosis, how it grades severity from mild to severe organ failure, and how that grade then dictates the entire management pathway.
It really is a roadmap.
It is. This isn't just academic. It's about streamlining care and getting better outcomes for our patients.
So this whole standardization effort,
Yeah.
it didn't just happen overnight with TG18. It was an evolution.
Right. It started earlier.
It did. The journey really began with TG's 07, the first Tokyo Guidelines.
Right.
And that was groundbreaking at the time because it introduced structured diagnostic criteria for the very first time.
It put some rules on the table.
Exactly. It said, let's look at local signs, systemic response, and imaging. And it gave us that first 3-tier severity grading.
So TG07 was the basic skeleton. How did we get from there to TG18?
Well, TG13 came next, and it mostly just refined those criteria, trying to boost the specificity and accuracy. But the real power of TG18 is that it's built on just a ton of validation.
So we know it works.
We know it works. All that data showed that the TG13 and TG18 criteria correlate really strongly with the things we care about. 30-day mortality, how long a patient stays in the hospital, conversion to open surgery rates, even medical costs.
So the grade actually predicts the outcome.
It has real prognostic power, and that's why it matters. It gives us a universal way to stratify risk. A grade 2 in Tokyo means the same thing as a grade 2 in Toronto.
Which is huge. Okay, so let's get into daily practice. It all starts with the diagnosis. How does TG18 separate a definite case from a suspected one?
This is where the structure is so important. You have to evaluate across 3 domains. Let's call them A, B, and C.
A, B, and C.
Right. A is your local signs, B is your systemic signs, and C is your imaging findings.
And here's where it gets really precise. For a definite diagnosis, you need at least one finding from each of those categories. Not 2 out of 3. It has to be A and B and C.
That's the rule, and it's intentionally strict. It stops people from relying on just, say, the ultrasound. But if you don't hit all 3, you might have a suspected diagnosis.
Which is what exactly?
That requires one local sign, so from category A plus either a systemic sign from B or an imaging finding from C.
Okay, so A plus B or A plus C. That seems designed to catch those ambiguous cases maybe in the middle of the night before you have the perfect imaging.
Absolutely. It's a safety net for triage. But for a definite diagnosis, you need the whole picture.
Okay, let's break down the categories. What's in A, the local signs?
That's your physical exam. It's the classic Murphy's sign that catch in the breath when you palpate the right upper quadrant. Or it could just be a mass pain or tenderness right there.
Pretty straightforward. And B, the systemic signs.
That's your objective data showing the body is fighting something. So a fever over 38 Celsius. Or elevated inflammatory markers. Specifically, a white blood cell count over 10,000. Or, and this is important, leukopenia count under 4,000, which can be a very bad sign. Or a CRP over 1.
Got it. And finally, C, imaging.
Right. And transabdominal ultrasound is your first go-to. You're looking for things that confirm the problem is in the gallbladder, like bile duct dilation over 7 millimeters, or just seeing the gallstones or signs of obstruction.
So by forcing clinicians to check all 3 boxes, you're really reducing that that clinical gestalt diagnosis that could vary so much from doctor to doctor.
Tremendously.
Yeah.
It improves reproducibility. It's about making sure we're all talking about the same disease.
Okay, that diagnostic framework is crystal clear. But like you said, the severity grading is what really drives management. The way you treat a grade I versus a grade 3 is, I mean, it's night and day.
Completely different worlds, and the system is designed to predict risk. Let's start with the easiest one, grade 1 or mild. By definition, this is a case of acute cholecystitis that does not meet the criteria for grade 2 or 3. It's just localized inflammation. No organ problems. This is the vast majority of cases we see.
The ones that are, relatively straightforward.
Exactly. Low surgical risk.
Yeah.
Things get more complicated with grade 2 or moderately severe.
And to be classified as grade 2, the patient needs to have at least 2 specific criteria, right?
2 of them, yes. And this is a signal that the patient has a much bigger systemic inflammatory response. The surgery is going to be harder, and the patient is at higher risk.
So what are those criteria?
You're looking for a higher white blood cell count, over 12,000,
right?
Or that persistent leukopenia under 4,000, or a higher fever over 39 Celsius.
But what I find really interesting about grade 2 is that it also includes things that aren't just about infection. It brings in things like age over 75.
Yes.
Or markers like bilirubin over 5 or a low albumin under 25. Those feel like markers of frailty.
That's a crucial point. That's exactly what they are. TG18 is smart enough to recognize that a 76-year-old with a high fever is fundamentally different from a healthy 40-year-old.
Their physiological reserve is just gone.
It's gone. So that age criteria is a flag. It's a warning sign that says, be careful, this patient is fragile. An early operation might be much riskier here.
Okay. And that brings us to the most severe category, grade 3.
Yes, grade 3 or severe. This one is defined by frank dysfunction of at least one organ system. This is an ICU patient.
And the definitions here are really specific. For cardiovascular dysfunction, it's not just low blood pressure.
No, it's shock-requiring catecholamines. You're on a pressor drip just to keep their blood pressure up.
And for respiratory?
It's a PaO-FiO ratio less than 300. So significant respiratory failure, probably on a ventilator.
Neurological is clouding of consciousness. Renal is oliguria or creatinine over 2.
And then you have hepatic dysfunction, which is an INR over 1.5, and hematologic, which is a platelet count under 100,000.
Any one of those puts you in grade 3.
Any single one. And that patient is in a high mortality situation. The focus immediately shifts from the gallbladder to just supporting the organs.
So how does all this grading then translate into what we actually do?
This is where the system really shines. The guidelines say you can't just look at the grade. You have to cross-reference it with the patient's overall fitness.
Using tools like the Charlson Comorbidity Index, the CCI, or the ASA score.
Exactly. You have to formally assess their frailty. Okay, so let's run through it. For a grade I patient, the mild cases. If they're fit, so a CCI of 5 or less and an ASA of 2 or less, the recommendation is crystal clear.
Early laparoscopic cholecystectomy during that same hospital stay.
Yes. The evidence is overwhelming. It reduces recurrence. It reduces total time in the hospital. You just get it done.
Okay, now for the gray zone, grade 2.
This requires more judgment. If the patient is fit same criteria, CCI under 5, ASA under 2, then early lap cold by experienced surgeons is still the way to go.
And that experienced surgeons part is written right into the guideline.
It is, and it's not trivial. Grade 2 cases are often a mess of lots of inflammation, maybe some necrosis. It's a harder operation. But if that patient is not fit,
if they're frail or have a lot of comorbidities,
and you back off. You start with medical therapy antibiotics and maybe gallbladder drainage, like a percutaneous cholecystostomy tube, and you plan for a delayed surgery way down the road.
You cool everything down first.
You cool everything down. And finally, management for grade 3.
Which, as we said, is about organ support first.
Absolutely. Urgent biliary drainage and ICU level support. Surgery is almost always deferred.
Yeah.
But TG18 did add one small allowance.
For select patients.
For a very select few. If you have a grade 3 patient with, say, a favorable organ failure profile, very few comorbidities, and you're at an advanced center with expert hepatobiliary surgeons, you might consider an early lap col after they're stabilized.
But that's a very high-level, multidisciplinary decision.
Extremely. The default is still stabilize, drain, and operate much, much later.
So the practical take-home is really to systematically document everything. The 5 key steps: local signs, systemic markers, imaging, severity grade, and the comorbidity score.
You have to. And it's easy now. The guidelines are available as free mobile apps you can use right at the bedside.
Looking back, the impact has been huge, hasn't it? These guidelines are in national policies everywhere. It allows us to compare apples to apples from a hospital in one country to another.
It's been transformative for research and quality improvement. But we have to be honest about the limitations.
Of course.
The whole system kind of assumes you have access to good imaging 24/7. If you're in a resource-limited setting, hitting that definite diagnosis can be tough.
And the scores can't replace clinical judgment?
Never. The guidelines are a map, but the clinician still has to drive the car. You have to look at the whole patient, their frailty, their social situation. The score is just one piece of the puzzle.
So practitioners need to be using the latest version -EG18 and just be ready for the next update. But this whole conversation brings up a really important question for me. Given how specific the guidelines are about needing an experienced surgeon for grade 2nd, or a whole advanced team for that select group of grade 3rd patients, how do centers that don't have that high-level expertise effectively manage these complex cases, even with the guideline? It really highlights that a standard on paper is one thing, but having the resources to execute it is another entirely.
That's the million-dollar question, isn't it?
It really is. And that brings us to the end of this deep dive on the Tokyo Guidelines 2018. We've covered diagnosis, the critical severity grading, and how that all connects directly to management.
We really hope this was a valuable synthesis for you in your clinical practice. And if you did find it helpful, please don't forget to share it with at least one of your colleagues or a friend. Help spread the word about standardized, evidence-based care.
And remember, you can find more deep dives just like this on our YouTube channel and our other social media pages. Thank you for joining us for this crucial discussion on standardization in acute cholecystitis.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.